Good afternoon everyone, my name's Kasia Bail and I'm talking to you from Canberra in Australia. I'm very grateful for the invitation to present to you today and I hope that you're enjoying the weather over in Sri Lanka. It's particularly windy here in Canberra, no idea what it's like over there. I'm going to admit that I've never done one of these before. I've done teleconference online but never presented to a conference using the web, although I will admit I'm not necessarily actually using the web because this is the backup video that you're probably watching. Welcome to my presentation. I'm presenting on behalf of Associate Professor Marion Curry and myself and the rest of our team here in Canberra. We also have one of our professors is Mari Botti from Deakin University, who did the initial valuation of the particular product that I'm going to talk to you about today. So as I'm sure you're all aware, background is that there's poor uptake of technology in healthcare delivery. There's inadequate and often incorrect clinical information. Sometimes this is as a result of multiple interfaces or not being at the direct source of care delivery. Confusing interfaces is an often reported issue. Clinicians often find them clumsy and not user-friendly. And in addition to that, they are often not designed to assist the clinicians necessarily in their point of care delivery. They're more designed to be collecting data. And that's one of the things that we're obviously interested in, is that here we have a whole wealth of data being collected by clinicians and they are also delivering healthcare, but sometimes these are at cross purposes and the one item of data collection and data entry isn't actually serving both purposes. And consequently there's excess time spent entering or retrieving or both the information, and so it's not necessarily that different to using paper technology. I went looking for some amusing anecdotes and jokes on this topic, and of course there are hundreds and they're all quite funny and often quite apt. I'm still a clinical nurse working in clinical areas about once a month, and I'm yet to find one myself that is user-friendly and actually helping to expedite care. Understanding nursing work, and this is something that is key to this particular system. Many of you, I'm not quite sure of the audience, but you may not be clinicians. And so nurses in an acute hospital area tend to complete up to 72 tasks per hour. So their mean task length is about 55 seconds. The duration of their work is often less than 10 seconds. And so they're multitasking much of that time. They're often considering a different patient every 6 minutes, whether they're asked about the patient or approached by a colleague. And they're interrupted by colleagues and patients every 6 minutes and interrupted every 60 minutes by work system failures, so things like medications and supplies not being available, having to go hunting for the particular machine that they're looking for, things like that. And up to 98%, so about half, but up to almost 100% of nurses report leaving at least one task undone during their shifts. The previous findings on this particular product called Smartward was that nurses halved the time that they spent documenting their care, and their interaction with patients increased threefold. More documentation was performed at the point of care rather than in other places such as the nurse's station. And this is one of those things where if you're documenting care, and sometimes people are documenting on their hands and then transcribing later, or they're trying to remember it before they go and write it down, this does increase the error rate, we know. And so in this particular study that was done down in Melbourne at one of the hospitals down there, 60% of documentation occurred at the bedside, whereas only 24% of it occurred previously prior to the implementation of this tool. And so the nursing activities performed at the bedside increased by 15% as well. And we know that even if nurses are increasing their attendance at the bedside, obviously the question with something like this bedside tool is that the nurses are spending more time with the machine rather than more time with the patient. But this is one aspect of the data that we'll be trying to collect. So the current situation, we were invited to evaluate Smartward as it's being implemented into a hospital in Canberra. It's been progressively developed over the last 7 years in conjunction with ward nurses. And there's quite a bit on the internet if you would like to have a bit of a look. You're probably all on your tablets there as well. About how it originated, which was from a fellow who observed nurses working in a hospital and the efficiencies that were occurring. And so he's worked very closely, and the other IT developers, with nurses on the floor because they are interested in actually making the care more efficient as well as having good documentation. It's now being rolled out this month into ACT Health, starting with a 26-bed medical ward of our tertiary hospital. And again, if you're interested in what the sizes of our hospitals to compare to your region, if you look up ACT Health and the Canberra Hospital, you'll be able to find out more information. We're servicing a population here of about 500,000, so it's probably minuscule in comparison to some of the areas in Sri Lanka, I suspect. The first stage of the product is what is being implemented initially, which is the interactive bedside nursing chart. This particular product has the capability to interact with other charts and documentation processes and to do all the progress notes and medication charts and things like that. But starting with first things first is the bedside nursing chart. And the comment I've got down there about it being managed by ACT Health is just to be keeping in mind any kind of health services research. You're not then just contending with development of the product, but also with the situation that you're rolling out into and the various hierarchies and decision-making processes that go with that. And I think it's a really important thing to keep in mind that not just is it interesting to see whether the tool is working, but always maintaining patient care. And that is first and foremost in any data collection, is what is happening for the patients and making sure that that's not compromised. And so often that means that it's a slow process to try and deliver a particular tool into the clinical area, and a gradual staged process about trying to get everybody on board and trying to make sure that the system is safe. So our research assumptions are that the digital bedside nursing chart, that is Smartward, will increase nursing time spent with patients and improve nurses' awareness of hospital clinical guidelines and support patient care decision making. Another word, I suppose, for improving nurses' awareness of clinical guidelines is compliance. That was one of the words that was previously used about making nurses more compliant. However, we know that we registered nurses so that they are autonomous professionals. So I think it's very important that we recognise that any of these tools which can assist decision making are doing just that, assisting. That the clinicians at the bedside are the ones making decisions based on the situation and the individual patient and the evidence to hand. But there's certainly a lot of scope to have prompts in a computer system to be helping the decision making that is occurring and making what is evidence-based knowledge available to hand. And so the ultimate hypothesis is that the use of the digital bedside nursing chart component of Smartward will result in better patient care and outcomes. And so the implementation details about where we're up to in regarding this. This particular Smartward device is located at the patient bedside and central nursing stations. They did experiment with using, a tablet that the nurse could walk around with, but really the nurses need their hands at all times, and so carrying something around just meant that it was more likely to get mislaid, and was another thing to be remembered. So having the chart at the bedside and immediately to hand up near the nurse's face and next to the patient was determined to be the best approach. And they've then done a lot of research making sure that these are then cleanable, because obviously you have a lot of infectious patients as well, and they need to be cleaned between patients, whether they're infectious or not. Replacing current paper nursing documents. So there are about 53 nursing charts, individual forms that nurses use. This particular rollout is starting with 11 of those forms, but they're the most often used forms and are expected to take up most of what the nurses' charting will require. And the implementation is to support the nursing care processes so that their planning, reviewing and documentation of patient care is occurring in this chart. It's communicating changes in delivery, so variations based on what perhaps the previous nurse had administered, and flagging these unfinished tasks. So say, for example, a patient comes in and has a high Waterlow scale. This is something that we use to assess what their skin is like and how likely they might be to get pressure injuries. The system can then flag that this patient needs 2-hourly repositioning, for example, and it can then flag if that 2-hourly repositioning has yet to be attended. So it can assist decision making in that way. It's easily accessible, it's real time, it's legible, and available to the whole multidisciplinary team. And so of course that has training aspects. The entire clinicians who access this particular ward are being trained in how to access this. But I'm sure, as you're all aware, a lot of this comes down to how easy the interface is to use. People are accustomed to picking up an iPhone these days and being able to flick through it and know how to navigate their way through it. And so the easier it is to access without much training, then the more effective it is likely to be. Our evaluation design is a pre-test, post-test design, and we've just commenced, we just finished the baseline data collection. The post-test design was hoped to be in early November. As with a lot of health services research, these things can get pushed back. So we're now looking at a slightly delayed data collection for the second data collection period. And that's why I've got the little poem down the end about getting closer and closer to Christmas. I'm quite accustomed to there being delays in start times. We can work with that, but it does get more difficult, particularly as some of the hospital function changes over Christmas time when surgery is closed and staffing can change. The data that we're collecting in the pre-test and post-test include nurse pedometer rates, so we're seeing how far the nurses walk, time and motion observation, so each of us data collectors will follow a nurse around to see what they're spending their time doing and where they're doing it. And we do this on a minute-by-minute basis for an hour at a time. We're doing questionnaires, focus groups, and these include both missed care data. We're interested in seeing what nurses and patients are reporting as being missed care. And we're also doing, in the post-test data, satisfaction surveys from the clinicians. We'll be doing focus groups with the nurses and doctors perhaps, but more often we'll be doing sort of bedside or hallway interviews with an ethnographic style where we'll be collecting information that they're reporting. We were quite aware that it was unlikely to be feasible to collect a lot of transcriptions on audio taping because we're in a live clinical environment, and it's inappropriate because you'll end up capturing people's words who haven't consented necessarily. We'll also use hospital data to have a look at pressure injury rates, pneumonia and things like that related to patient care quality. However, it's only a short data collection period, as you can see, so we're in only one single ward, so we're unlikely to gain statistical significance, but it will still be interesting to have a look at trends. So of the baseline data that we've been able to collect already, we followed 35 nurses around in 92 different observation periods, totaling 82 hours. 37 of these were morning shifts, 37 were afternoon shifts. So the morning shift here is 7 till about 3:30 in the afternoon. The afternoon is 1 p.m. until 9:30 at night, and the night shift is from 9 p.m. until 7:30 a.m. The locations that we observed in the nurses working is that 31% of their time was spent in hallways. Part of this is because the nursing charts are kept on the wall outside patient rooms, and so a lot of documentation was occurring outside the patient room, which was essentially in the hallway rather than even at the nurse's desk or in the patient room. 36% of nurses' time was spent at the bedside or in the bathroom. 81% of time was spent providing patient care, and of that, about 40% was direct patient care, so with the patient in the bathroom or the bedroom, or walking with them, for example, and 60% was on indirect patient care. So this was documenting that care primarily, or perhaps communicating with colleagues. 10% of time was spent hunting and gathering, so that was where they went looking for the paperwork. And this will be the interesting one to see if it does change when we have the digital bedside chart, in that they won't need to go looking to say, well, where did the doctor put that last, or where did I put that last? 54% of that time involved an interruption, and so this could be pertinent as well in that clinicians, rather than being in the hallway where they can be interrupted, they'll be at the bedside where they're less likely to be sought out. Often those interruptions were just opportunistic, if you like. 9% of nurses' time was spent on system care, so that might be self-care like drinking water or going to the bathroom, or perhaps talking to a colleague about how their weekend was, and 28% were meetings. There were other things like doing what we call riskman entries, so reporting accidents and incidents, but they were small in the time period that we observed. On average, the nurses were walking 7.5 kilometres a shift. That was 9,000 and a bit steps. They were considering a different patient 17 times an hour, so it might be the same 4 patients if you like, but they had to swap between from one to another. That might be that they were looking after one patient or doing documentation for one patient, and then a colleague interrupted them about a different patient. And again, this is important because these are those interruption times that are, again, less likely to occur if they're focused at the bedside on one patient and documenting one patient, and they're less accessible for those kinds of interruptions. But so that means that they're potentially considering a different patient every 3.5 minutes. And this is important when we're thinking about documentation and how we're making electronic fields accessible to nurses as to what they need. Some of those interruptions are very valid, they make care function. Oh, I'm about to run out of time. Multitasking minutes, 54% of the time nurses were spent doing 2 things at once.